It was really exciting to be involved in the ECHELON-2 as an investigator because, first of all, this was the largest trial of its kind looking at a novel upfront therapy for patients with PTCL. It obviously involved screening for CD30, so there was a learning curve, at each institution about getting CD30 expression data, and then it was really exciting to follow the trial and, wait for the results to be revealed.
The ADCETRIS plus CHP experience. ECHELON-2 data in frontline CD30-expressing PTCL. ADCETRIS is indicated for the treatment of adult patients with previously untreated systemic anaplastic large cell lymphoma, or sALCL, or other CD30-expressing peripheral T-cell lymphomas, or PTCL, including angioimmunoblastic T-cell lymphoma and PTCL not otherwise specified, in combination with cyclophosphamide, doxorubicin, and prednisone. ADCETRIS has a boxed warning for progressive multifocal leukoencephalopathy, or PML. JC virus infection resulting in PML and death can occur in ADCETRIS-treated patients. Please see additional important safety information at the end of this video and full prescribing information, including boxed warning for ADCETRIS at ADCETRISPro.com.
I'm Dr. Francine Foss, a hematologist-oncologist at Yale Cancer Center. Throughout this video, I will be specifically discussing the use of A plus CHP for the treatment of adults with newly diagnosed systemic anaplastic large cell lymphoma or other CD30-expressing PTCL. ECHELON-2 was the first and only prospective Phase 3 trial in frontline PTCL. The trial had a double-blind, double-dummy, and actively controlled design. 452 patients were randomized 1-to-1 to receive A plus CHP or CHOP every 3 weeks for 6 to 8 cycles. ADCETRIS was given at a dose of 1.8 milligrams per kilogram in combination with CHP. Subtypes enrolled included systemic anaplastic large cell lymphoma, peripheral T-cell lymphoma not otherwise specified, angioimmunoblastic T-cell lymphoma, adult T-cell leukemia lymphoma, and enteropathy-associated T-cell lymphoma. Patients had to have CD30 expression in at least 10% of neoplastic cells per immunohistochemistry, and the trial excluded patients with grade 2 or higher peripheral neuropathy. The primary endpoint was progression-free survival per independent review facility, defined as progression, death from any cause, or receipt of subsequent anti-cancer therapy to treat residual or progressive disease. Key secondary endpoints included overall survival and complete response. When we see a clinical trial like ECHELON-2 and we actually see a survival benefit compared to CHOP, that really means something to us. It means something to our patients. We had a progression-free survival that was better, and I think the thing that surprised us the most was the survival benefit, because in most of these clinical trials you don't really see a survival benefit. So that, I think, was really the most impressive take-home message for me from this clinical trial. A plus CHP more than doubled the median progression-free survival, from 20.8 months for the CHOP arm to 48.2 months for A plus CHP. A plus CHP reduced the risk of a progression-free survival event by 29%, and this was statistically significant versus CHOP. A plus CHP has demonstrated significantly longer overall survival, with a 34% reduction in the risk of death. The median overall follow-up time for both arms was 42.1 months, and the median overall survival has not been reached in either arm. The most common adverse reactions reported in greater than or equal to 20% of A plus CHP patients were anemia, neutropenia, peripheral neuropathy, lymphopenia, nausea, diarrhea, fatigue or asthenia, mucositis, constipation, alopecia, pyrexia, and vomiting. Serious adverse reactions occurring in greater than 2% of A plus CHP patients included febrile neutropenia, pneumonia, pyrexia, and sepsis. Well, I had a suspicion it would probably be a positive study in the anaplastic large cell lymphoma patients, but it was really interesting to see the data and the positive results across all different subtypes of PTCL, progression-free survival benefit, and even overall survival benefit, which is something that I don't think any of us really expected to see. If you actually look at the approval of ADCETRIS in the upfront study with ADCETRIS plus CHP. The FDA guidelines and the actual approval is for any expression of CD30. And so taking that data in hand, in my clinical practice, I seriously consider, or in fact use A plus CHP in many of my patients who have any level of expression of CD30. So it's become a treatment that I'm using across a broad range of PTCL subtypes.
Indication and important safety information. ADCETRIS, brentuximab vedotin, is indicated for the treatment of previously untreated sALCL or other CD30-expressing PTCL, adult patients with previously untreated systemic anaplastic large cell lymphoma, sALCL, or other CD30-expressing peripheral T-cell lymphomas, PTCL, including angioimmunoblastic T-cell lymphoma and PTCL not otherwise specified in combination with cyclophosphamide, doxorubicin, and prednisone. Important safety information. Boxed warning. Progressive multifocal leukoencephalopathy, PML. JC virus infection resulting in PML and death can occur in ADCETRIS-treated patients. Contraindication. Contraindicated with concomitant bleomycin due to pulmonary toxicity, e.g. interstitial infiltration and/or inflammation. Warnings and precautions. Peripheral neuropathy, PN. ADCETRIS causes PN that is predominantly sensory. Cases of motor PN have also been reported. ADCETRIS-induced PN is cumulative. Monitor for symptoms such as hypoesthesia, hyperesthesia, paresthesia, discomfort, a burning sensation, neuropathic pain, or weakness. Patients experiencing new or worsening PN may require a delay, change in dose, or discontinuation of ADCETRIS. Anaphylaxis and infusion reactions. Infusion-related reactions, IRR, including anaphylaxis, have occurred with ADCETRIS. Monitor patients during infusion. If an IRR occurs, interrupt the infusion and institute appropriate medical management. If anaphylaxis occurs, immediately and permanently discontinue the infusion and administer appropriate medical therapy. Pre-medicate patients with a prior IRR before subsequent infusions. Pre-medication may include acetaminophen, an antihistamine, and a corticosteroid. Hematologic toxicities. Fatal and serious cases of febrile neutropenia have been reported with ADCETRIS. Prolonged, greater than or equal to 1 week severe neutropenia and grade 3 or 4 thrombocytopenia or anemia can occur with ADCETRIS. Administer G-CSF primary prophylaxis beginning with cycle 1 for adult patients who receive ADCETRIS in combination with chemotherapy for previously untreated stage 3 or 4 CHL, or previously untreated PTCL or relapsed or refractory LBCL, and pediatric patients who receive ADCETRIS in combination with chemotherapy for previously untreated high-risk CHL. Monitor complete blood counts prior to each ADCETRIS dose. Monitor more frequently for patients with grade 3 or 4 neutropenia. Monitor patients for fever. If grade 3 or 4 neutropenia develops, consider dose delays, reductions, discontinuation, or G-CSF prophylaxis with subsequent doses. Serious infections and opportunistic infections. Infections such as pneumonia, bacteremia, and sepsis or septic shock, including fatal outcomes, have been reported in ADCETRIS-treated patients. Closely monitor patients during treatment for infections. Tumor lysis syndrome. Patients with rapidly proliferating tumor and high tumor burden may be at increased risk. Monitor closely and take appropriate measures. Increased toxicity in the presence of severe renal impairment. The frequency of greater than or equal to grade 3 adverse reactions and deaths was greater in patients with severe renal impairment. Avoid use in patients with severe renal impairment. Increased toxicity in the presence of moderate or severe hepatic impairment. The frequency of greater than or equal to grade 3 adverse reactions and deaths was greater in patients with moderate or severe hepatic impairment. Avoid use in patients with moderate or severe hepatic impairment. Hepatotoxicity. Fatal and serious cases have occurred in ADCETRIS-treated patients. Cases were consistent with hepatocellular injury, including elevations of transaminases and/or bilirubin, and occurred after the first ADCETRIS dose or re-challenge. Pre-existing liver disease, elevated baseline liver enzymes, and concomitant medications may increase the risk. Monitor liver enzymes and bilirubin. Patients with new, worsening, or recurrent hepatotoxicity may require a delay, change in dose, or discontinuation of ADCETRIS. PML. Fatal cases of JC virus infection resulting in PML have been reported in ADCETRIS-treated patients. First onset of symptoms occurred at various times from initiation of ADCETRIS, with some cases occurring within 3 months of initial exposure. In addition to ADCETRIS therapy, other possible contributory factors include prior therapies and underlying disease that may cause immunosuppression. Consider PML diagnosis in patients with new onset signs and symptoms of central nervous system abnormalities. Hold ADCETRIS if PML is suspected, and discontinue ADCETRIS if PML is confirmed. Pulmonary toxicity. Fatal and serious events of non-infectious pulmonary toxicity, including pneumonitis, interstitial lung disease, and acute respiratory distress syndrome, have been reported. Monitor patients for signs and symptoms, including cough and dyspnea. In the event of new or worsening pulmonary symptoms, hold ADCETRIS dosing during evaluation and until symptomatic improvement. Serious dermatologic reactions. Fatal and serious cases of Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, TEN, have been reported with ADCETRIS. If SJS or TEN occurs, discontinue ADCETRIS and administer appropriate medical therapy. Gastrointestinal GI complications. Fatal and serious cases of acute pancreatitis have been reported. Other fatal and serious GI complications include perforation, hemorrhage, erosion, ulcer, intestinal obstruction, enterocolitis, neutropenic colitis, and ileus. Lymphoma with pre-existing GI involvement may increase the risk of perforation. In the event of new or worsening GI symptoms, including severe abdominal pain, perform a prompt diagnostic evaluation and treat appropriately. Hyperglycemia. Serious cases such as new onset hyperglycemia, exacerbation of pre-existing diabetes mellitus, and ketoacidosis, including fatal outcomes, have been reported with ADCETRIS. Hyperglycemia occurred more frequently in patients with high body mass index or diabetes. Monitor serum glucose, and if hyperglycemia develops, administer anti-hyperglycemic medications as clinically indicated. Embryo-fetal toxicity. Based on the mechanism of action and animal studies, ADCETRIS can cause fetal harm. Advise females of reproductive potential of this potential risk and to use effective contraception during ADCETRIS treatment and for 2 months after the last dose of ADCETRIS. Advise male patients with female partners of reproductive potential to use effective contraception during ADCETRIS treatment and for 4 months after the last dose of ADCETRIS. Adverse reactions. The most common adverse reactions, greater than or equal to 20% in adult patients, are peripheral neuropathy, nausea, fatigue, musculoskeletal pain, constipation, diarrhea, vomiting, pyrexia, upper respiratory tract infection, mucositis, abdominal pain, and rash. The most common laboratory abnormalities, greater than or equal to 20% in adult patients, are decreased neutrophils, increased creatinine, decreased hemoglobin, decreased lymphocytes, increased glucose, increased ALT, and increased AST. The most common grade greater than or equal to 3 adverse reactions greater than or equal to 5% in combination with AVEPC in pediatric patients were neutropenia, anemia, thrombocytopenia, febrile neutropenia, stomatitis, and infection. Drug interactions. Concomitant use of strong CYP3A4 inhibitors has the potential to affect the exposure to monomethyl arostatin E, MMAE. Closely monitor adverse reactions. Use in special populations. Lactation. Breastfeeding is not recommended during ADCETRIS treatment. Please see full prescribing information, including boxed warning, for ADCETRIS.